Sanya here? Please come and present.
Sanya, no? Sanya.
Good morning everyone. I'm going to present about clinical characteristics of tubercular choroiditis patients presenting at a tertiary care center of Uttarakhand. Myself Sanya Kapu. My first co-author is Dr. Ajay Agarwal. My second co-author is Dr. Ramanus Samanta. The aim is to study the clinical characteristics of tubercular choroiditis patients presenting at a tertiary care center over 1 year. The secondary objective of this study was to compare the mean score of online COTS, Collaborative Ocular Tuberculosis Study Calculator, among different subtypes of tubercular choroiditis patients. The method this was actually a hospital-based prospective study conducted at a tertiary care center at Uttarakhand over 1 year in August 2023 to July 2024. Treatment-naive tubercular choroiditis patients of age greater than or equal to 18 years were included in the study. The tubercular choroiditis were actually defined according to COTS guidelines, Collaborative Ocular Tuberculosis Study, and was classified further into serpiginous like choroiditis SLC, multifocal choroiditis MFC, focal choroiditis FC, and tuberculoma. All patients underwent routine laboratory investigations like CBC, KFT, LFT. Along with them, TST, tuberculin skin test, interferon gamma release assay IGRA, chest imaging like chest X-ray or CECT, and other investigations as felt necessary were done. Online COTS calculator was used to calculate median score ranging from 1 to 5. Choroiditis patients with non-tubercular etiology were excluded. Patients with incomplete laboratory investigations were also excluded. Were diagnosed with tubercular choroiditis with male preponderance. Among 14 patients, 6 patients were of SLC, which is 42%, and 5 patients had MFC, which is of 35%, and 3 patients had tuberculoma. And TST positivity rate was 100% across all the 3 subtypes of SLC, MFC, and tuberculoma, while IGRA positivity rate was 100% in SLC, 60% in MFC, 66.6% in tuberculoma. The chest imaging revealed evidence of active or old infection in 66% of SLC and tuberculoma patients and 80% in MFC patients. The mean COTS calculator score was 5 in both SLC and tuberculoma group of patients and 4.5 in MFC group. All 14 patients with tubercular choroiditis received ATT, anti-tubercular treatment with systemic steroids. These are the pictures of SLC patient before ATT and after ATT, MFC patients and tuberculoma patients. Like we said, among 6 patients of SLC, all the 6 patients were positive for TST, all the 6 patients were positive for IGRA, and 2 patients showed old lesions on chest X-ray, 2 patients showed active lesions, and 2 patients shows normal chest X-ray. Thus, the median COT score was 5. In MFC, 5 patients were diagnosed with TST positive and 3 patients IGRA positive. 3 had old lesions and 1 had active lesions over chest X-ray, 1 with normal chest X-ray with a mean COT score of 4.5. In tuberculoma patients, among 3, all the 3 are TST positive, IGRA of 2 are positive, and chest X-ray active lesions are found in 2 patients and 1 patient is having normal chest X-ray and median score is of 5. Like we are having mostly SLC diagnosed patients, after that MFC with 5 and tuberculoma of 3. And we have diagnosed this criteria based on the COTS guidelines.
Please summarize.
According to COTS guidelines, we have taken only Montus, IGRAs and radiological tests like CCT and chest X-ray without any confirmed test of histopathology and PCR test to diagnose tubercular uveitis. On this COTS guidelines, this is the COTS calculator where we generally present with patient name, details and all, along with the clinical phenotype, endemicity of the patient and TST, IGRA, chest X-ray scans, which we came to know that the median score is 5, which represents very high probability for most experts to consider ATT treatment. Thus, we concluded that SLC is the most common type in our study cohort and TST was universally positive among TC, IGRA and all. And COT score was highest in SLC and tuberculoma group and all the 14 patients were received ATT and systemic corticosteroids.
Thank you very much.
So, how did you diagnose SLC? Like, what is the differentiating features that you kept in mind to diagnose a serpiginous-like choroiditis from serpiginous choroiditis?
Ma'am, serpiginous-like choroiditis will be having lesions starting with small lesions and it will expand as a serpiginous patient with active part over.
No, just tell me the differentiating, like how did you, when you saw the patient clinically, how would you know this is serpiginous-like and not serpiginous? Because in serpiginous-like, it has a tubercular etiology and serpiginous doesn't. So what are the differentiating factors? How did you classify them into SLC? Just the 2-3 points that you would think of. No, you don't know about that.
You have excluded all non-tubercular cases. What was the criteria for the tubercular choroiditis? Did you know beforehand that this patient is having tuberculosis?
No sir, after coming we will see the lesions and we will prescribe.
So once you are seeing patient in outdoor and you are diagnosed a case of choroiditis, at that time you will exclude or you will examine all the cases, then you exclude the cases of non-tubercular cases. I mean just asking how do we label that this case is a tubercular choroiditis and that case is a non-tubercular choroiditis? How will you differentiate? Then only you can include or exclude from your study, no? Bataiye.
We will first send for investigation sir and investigations if it is Montus positive or IGRAS positive along with chest X-ray findings we will label him under tubercular or non-tubercular. If he is under tubercular then we will differentiate him to SLC and MFC.
These all tests can be positive or Montux is a very non-conclusive test.
Yes.
Even you test your Montux, it will be positive,
Yes,
right?
Yes sir.
And all these tests are also found in allergy to tubercular
Yes.
protein or the type 4,
Yes sir.
you know,
Yes sir.
type 4 hypersensitivity.
Yes.
So how will you differentiate whether it is a tubercular or a type 4 type of reaction?
Actually, sir, we are following COTS guidelines. According to COTS guidelines, it is mentioned in the definition that it is of tubercular origin. If it is like positive for any radiological test like IGRA or TST, along with radiological tests like chest X-ray and CECT, without any PCR histopathological findings.
Correct. Okay. Thank you very much.
All the patients had CECT done here, all these patients?
Chest X-ray we have done primarily, ma'am. If it is like
So, all the patients had a CECT in your series?
not all the cases, ma'am. If chest X-ray findings we are having any doubt, then we are proceeding for CECT.
Did you check for the ethambutol toxicity during your treatment and your
Yes, sir. We are checking for ethambutol
what kind of
toxicity
test?
also.
What test did you do to exclude whether the patient is developing neuritis because of the ethambutol toxicity?
Actually, we are seeing posterior fundus
Only
findings.
vision or something else?
Yes, sir. Vision and fundus findings on
And?
dysphagia and all.
Field test? No.
Field test also.